My name is Joshua Royce. I'm a thoracic medical oncologist at Georgetown Lombardi Comprehensive Cancer Center in Washington, D.C. And in this session, I will be discussing immune checkpoint blockade in malignant pleural mesothelioma with a focus on biologic rationale and use as subsequent line therapy. There is strong biologic rationale for immune checkpoint blockade in malignant pleural mesothelioma. Mesothelioma has found to demonstrate a high rate of PD-L1 positivity that appears to be associated with histology and survival. PD-L1 positivity rates have ranged from 20 to 70% in retrospective studies, appear to be associated with non-epithelioid histology, prior chemotherapy, and poor survival, as demonstrated on the figure on the right. Reasons for this wide range of PD-L1 positivity are likely related to the varying numbers of patients with non-epithelioid histology and prior chemotherapy use in these studies. In addition to PD-L1 positivity, a high frequency of gene expression signatures associated with an adaptive immune response and inflamed tumor microenvironment have been observed in mesothelioma. Furthermore, a high burden of potentially immunogenic chromosomal rearrangements has been seen. This is despite an apparently low tumor mutation burden by standard techniques compared to other tumor types with similar response rates to checkpoint blockade in the subsequent line setting. This is likely related to this large burden of chromosomal rearrangements, as these chromosomal rearrangements are more difficult to detect utilizing standard techniques for tumor mutation burden. This is a summary slide of phase 2 single-arm studies of checkpoint blockade in the salvage setting. As you can see, response rates were on the order of around 20 to 29%, with disease control rates ranging from 40 to 70%, median progression-free survival of 2.6 to 6 months, and a median survival of on the order of 12 to 18 months. The reason for variation of these studies is likely related to their small sample size. Taking a deeper dive, this is the Japanese phase 2 MERIT study of nivolumab in platinum-refractory advanced mesothelioma. This was a single-arm, open-label phase 2 trial of patients who had progressed on prior platinum therapy. Patients were given nivolumab until disease progression or unacceptable toxicity, and the primary endpoint of this study was overall response rate. As you can see here, nivolumab demonstrated encouraging clinical efficacy in this study in patients with platinum-refractory malignant pleural mesothelioma, with an overall response rate of 29%, disease control rate of 68%, and a median survival of 17.3 months. As you can see on the left, patients with PD-L1 positivity demonstrated a numerically higher median survival of 19.1 months, compared to 11.6 months in patients that were PD-L1 negative, though I caution against any determination of PD-L1 as a potential biomarker based off of these results. On the right side, you can see that patients with biphasic or sarcomatoid histology had numerically higher survival of 26.6 months compared to 15.7 months with epithelioid histology. Again, these are small numbers, but this will become more relevant as we discuss immune checkpoint blockade in the first-line setting. Based off of this study's results, nivolumab was approved in the subsequent line setting in mesothelioma patients who had progressed on platinum chemotherapy in Japan. However, we await results from the phase 3 randomized confirmed trial of nivolumab versus placebo in treatment-refractory mesothelioma. This study has accrued with results pending. We do, however, have results from a phase 3 trial of checkpoint blockade versus institutional choice chemotherapy in the subsequent line setting, and this is the phase 3 PROMISE meso study. This was a phase 3 trial of patients who had progressed on prior platinum-based chemotherapy and were randomized to pembrolizumab versus single-agent institutional choice chemotherapy. Crossover was allowed in this study. Patients were stratified by histology, and the primary endpoint of this study was progression-free survival. Unfortunately, pembrolizumab failed to demonstrate an improvement in progression-free or overall survival over single-agent chemotherapy despite a numerically greater response rate. Shown here are the survival curves for progression-free survival, and you see considerable overlap, and on the right you see that no subgroup benefited from pembrolizumab over chemotherapy. Shown now are similar results for overall survival, again with overlap in their survival curves, and no subgroup demonstrated a benefit of pembrolizumab over chemotherapy. Again, this is despite a numerically greater response rate of 22% with pembrolizumab compared to 6% with chemotherapy, suggesting that responses to pembrolizumab were transient. This does not mean that checkpoint blockade shouldn't be considered in the subsequent line setting in mesothelioma. It just indicates that further research is needed to identify the patients most likely to benefit. Moving on to combination checkpoint blockade, this is a summary slide of phase 2 single-arm studies of combination PD-1 pathway and CTLA-4 inhibition in the salvage setting in mesothelioma. And as you can see, response rates in these studies were on the order of 28 to 29%, with disease control rates of 50 to 68%, median progression-free survival of around 5.5 to 6 months, and a median survival of 16 to 16.5 months. Taking a deeper dive, this is results from the MAPS-2 study. This is a phase 2 randomized non-comparative trial of nivolumab and nivolumab plus ipilimumab. And as you can see here, the combination demonstrated a numerically greater response rate with a numerically higher median survival of 15.9 months compared to 11.9 months with single-agent therapy. This is a summary of NCCN recommendations for the subsequent line setting for systemic therapy in mesothelioma. And as you can see here, both nivolumab with or without ipilimumab and pembrolizumab carry a Category 2A recommendation by the NCCN in the subsequent line setting in mesothelioma. It should be noted, however, that neither therapy is formally FDA approved in this setting. In conclusion, with high rates of PD-L1 positivity and an inflamed tumor microenvironment, as well as high burden of potentially immunogenic chromosomal rearrangements, there is strong biologic rationale for immune checkpoint blockade in malignant pleural mesothelioma. Multiple single-arm phase 1-2 studies have demonstrated encouraging signals of clinical efficacy for anti-PD-L1 plus or minus anti-CTLA-4 immune checkpoint blockade in platinum-refractory mesothelioma, resulting in Category 2A recommendations by the NCCN for both pembrolizumab and nivolumab with or without ipilimumab in the subsequent line setting. However, in the only randomized trial of immunotherapy in the subsequent line setting with results, a phase 3 study, pembrolizumab failed to demonstrate an improvement in progression-free or overall survival compared to single-agent chemotherapy. Again, this does not mean that patients in the subsequent line setting don't benefit from immunotherapy. It just suggests that we have further work to do to determine the patients most likely to benefit. However, and most important, the role for immune checkpoint blockade in the subsequent line setting is likely to evolve considerably given promising results from trials incorporating immune checkpoint blockade in the frontline setting, namely Checkmate 743, DREAM, PRECOG, and other phase 3 studies that are actively accruing. We will discuss several of these studies in subsequent sessions. That concludes this session. Thank you for your attention.